computer. All right. Great. Welcome, welcome. This is Dr. Garias, and this is, I believe, MED, is it 140? 260. So, like I stated last week, the beginning parts of this lecture is kind of like a quick review over some of the items that you should have went over MED 140 basic clinical procedures, because again, like last week, the way office visit works is it starts as subjective, which is the history taking, which is what we did last week. Then it becomes the objective, which is this week. Now, part of the objective stuff is the evidence at which we get to the diagnosis, which is the A part of the SOAP, which is the assessment or the diagnosis. So physical examination, this is where we're finding signs. And signs are different from symptoms because signs are what everyone gets to see. And like last week's lecture, we talked about fever. So if the patient just says, oh, I'm feeling a little bit feverish, that's not a sign. That is a symptom. I don't know. I don't have any data. I wasn't there when when there was an actual recorded fever. And remember, something like pain is subjective. But if someone's really experiencing pain, their blood pressure is going to be a little bit up. Heart rate's going to be a little bit up, especially if there's going to be guarding, especially if I touch the area that's painful. My patient will, they'll kind of retreat back a little. Another sign is called grimacing. They'll try to hide it, but you'll see the wrinkles in your forehead if you start touching something that's painful. So the physical examination is important, and the discussion I wrote down was, and someone answered it. It was like, medical assistants don't usually do the physical examination. Well, that's true, but the question that I had really for discussion too is, like, when you go to a typical doctor's office visit, can you research why the doctor doesn't go through an entire physical examination from head to toe, from your head to toe assessment, right? So I already went over the general purpose of the physical examination. It's to get data, because you can't just have a diagnosis without any data. And that's what this lab class is about. It's about the ways the different departments receive data, get objective stuff. So objective, not stuff, but objective results, a sign that we all can see that can be evidence for the diagnosis. And in the last 2 decades, there has been a switch in medicine called evidence-based medicine. Even though I have an idea that you have a cold, I need evidence to back me up. And one way I could do that is physical exam. And for the weeks to come, another way I could do that is with lab results. But we need the physical examination to corroborate with the lab results. And that's what I'm saying, right? Your role as a medical assistant is to, of course, from MED 140, is to assist. Okay. And how can you assist if you don't know why I'm doing the things I'm doing? And typically, if the doctor does do a PE or a physical examination, we do it very fast. Internal medicine, I should be able to do a head-to-toe assessment in 20 minutes. I remember in medical school when I first started, it took me like an hour each patient. My attending used to get very upset that I was very, very slow. But after a while, you get to, there's shortcuts and there's other things of that nature. But nowadays, you go to the doctor, they take one look at you and then they just give you meds. So I want you guys to investigate that for discussion too. Why do doctors do that? Or why do NPs do that? Safety precautions, of course, your universal precautions, that's already assumed. Showed you steps. We're going to go through positioning and how to drape the patient. And I'll be announcing, hopefully by this Friday, tomorrow, or maybe Monday of next week, the laboratory schedule. And if you can't make that schedule, that's okay. Shoot an email to me, say, Dr. Grice, I can't make this. And then give me a date that works with you, and then we'll meet on the campus. But there are guidelines on how to take the elevators and what to wear, and where to put your things, so that we're going to try to minimize contact with each other, and we're trying to minimize how many people are on campus at any given time, because not only we have to have our laboratories, the nurses also have to have their laboratories, and they're on the same floor as we are, on the fourth floor. And we also have culinary, who have their laboratories on the fifth floor. So we're all trying to get together. We actually did get together yesterday. The university is trying to figure out a schedule to minimize the number of people on campus for this term. Techniques to assist patients in different cultures and patients with physical disabilities. Those of you who are CNAs already know how to get people in and out of chairs, in and out of beds, in a safe manner. But also different cultures. We're going to mention briefly on how there's some cultures they're very close, they're very touchy, and there are other cultures that are very that, because due to religious reasons, you shouldn't be touching people. But we're in the touching business, so again, you always ask for consent. 6 examination methods, and of course, we're going to just go through, like we stated earlier, we're going to go through the parts. So going down here, I wrote more key terms and other items, and we now know the difference. Between. Why is this not cooperating with me? Okay, here. We now know the difference between subjective and objective. And what we're talking about today is objective. The evidence that was required to get me my diagnosis. But subjective too, I need that as well. Because remember, the word diagnosis is a state or condition of complete and thorough knowledge. So I'm going to need both. But this is the physical examination is the first part of the objective. Now, the first part of the physical examination, depending on what book you talk about, is, but for me, it is the vital signs, which we'll be going over in class. Look up your normal vital signs if you don't know them for a typical patient. A typical patient in medicine is a 70-kilogram male, the normal vital signs for blood pressure, respiratory rate, heart rate, and temperature stand. No matter what country you're in, and no matter what size you're in, they should stand uniform, with the exception of blood pressure. And we're going to talk a little bit more about that. Well, heck, I'll talk about it now. Blood pressure, blood pressure also depends on not only your history and your current physical status. It also deals with also a little bit heredity, and again, size of the patient. For example, I have a niece. She's in her 30s, but she's maybe 95 pounds. She's 4'11" and barely 95 pounds. Her normal blood pressure, is typically like 100/60, right? So even though 120/80 is your typical blood pressure for a 70-kilogram man, for her, if she had 120/80, she would be hypertensive, right? And then when she got pregnant, people were looking at her blood pressure like 120/80 as normal, when in actuality it was increased drastically from her typical 100/60, 90/60. So regarding blood pressure, it's going to have some genetic and anatomic variation, but again, right? If you look, another reason for the history is, which is a common test question on your CCMA or RMA exams. They sometimes ask the question is, what is the purpose of taking a history? Now, of course, beyond the obvious reasons, the official legal reason on why we write everything down is because we want to prove continuity of care. So that means I'm looking at not only before I saw my patient, I'm looking at what I'm doing to my patient right now, and also I'm also documenting what I'm planning to do, and that's the P part of the SOAP. So you have your subjective, objective, assessment, which is your diagnosis, and then P, the last P of SOAP, is plan, right? Now, your precautions, universal precautions, you should know that from any MED 140. Kindly review those. So let's go over, I wrote now next, let's go over exam positions. Now, certain tests require the patient to be in certain positions. So nice little homework that you can do, and it should be a nice review from your MED 140, and sometimes some of the professors teach it in anatomy and physiology. Know your exam positions, and when we're in laboratory, we'll just review them, and we'll also be in the laboratory with um, what do you call that, the laboratory table, and we're going to go over them. So when you review these positions, look up not only what they look like, you also look up what is the main reason why we have the patient in these positions. Okay, so that's like a nice little homework for you, which is required for you to know the future tests, because there'll be certain tests like, oh, this test that must be done in prone, this test must be done in sims. Okay, now the examination methods, what are they? Like this is a head to toe assessment, but we always start with inspection, and that is when, you know, when you just meet your patient and just say hello to them and you identify yourself, you look at them. How's their skin? How's their hair? How is their personality when they're meeting you? Are they too friendly? Are they not friendly enough? There's something called a precox feeling. Have you ever had like like you met somebody and they were a little off? They said all the right things and they did all the right things, but you know there's something off. That's called precox in psychology and psychiatry, or precognitive, because someone with considerable mental disease or defect, they're going to start showing, things, and just little things that might be off, and you pay attention to that. Another thing you pay attention to is how, not only their skin, how's their hair, how's their appearance. Use all of your senses. Do they smell right? Right? Do they look unkept, or do they look disheveled for somebody who's come visit the office? Do they dress bizarrely? These are things that you look upon inspection. Another thing in inspection that we always like to look at is musculoskeletal. How did my patient walk into the room? How did they stand up or sit? How was their handshake to you, if there was a handshake or any other contact? So inspection is a broad term, but it's where you use all of your senses and to get to get to start to form your observations and the things that you see. Now, auscultation, of course, that's when you listen, and it's more of the doctor's job. But auscultation is when we use the stethoscope, and if you recall, the stethoscope had let's, instead of me just talking about it, let me just show you. Remember, the stethoscope had like parts. Okay. And remember, it had this big flat part and this little cone part. And the flat part is called the diaphragm, and the smaller one is called the bell. Now, we do chest auscultation. I can also use this on your abdomen, because you also have bowel sounds, which you may know about, right? When you eat something, or when you're hungry, your stomach makes, your stomach or your abdominal area makes funny squirty sounds. Well, we also measure those as well in medicine. And the bell is usually used for cardiac. but can also be used for pulmonary. The bell is used for low frequency sounds, and the diaphragm is used for everything else. So that's auscultation. When I'm trying to listen to lung sounds, I'm trying to listen to heart sounds, and I could also listen to bowel sounds or sounds in your abdominal area, whether it be your stomach or your intestines. All right, what am I doing here? Okay, back to my notes, which is here. Okay. Now, palpation. Now, of course, palpation is touching. I have to touch my patient. I have to check a range of motion. But the main reason for palpation, and let's get this here, is this lymphatic system. If you recall your anatomy and physiology, you have a lymphatic system, and in real life, of course, it's not green, but we picture it in green. Let's see if I can get a bigger picture of this. Good. So your lymphatic system here, and we know that, if you get a little like a sore throat or a bad toothache, what happens? Your lymph nodes will get it'll get enlarged and sometimes even painful. So when the doctor is feeling or palpating your neck, and then they go down your shoulders, your axillary area, especially for women who regularly perform their breast self-examination. When I'm looking for a mass or a potential mass in the mammary area or the chest area, I also have to check these axillary lymph nodes. I also check what is also called, here it looks like a necklace, that's called the rachitic chain. Rachitic means rosary. And where do you wear a rosary? If you're Catholic, you wear it around your neck, right? And it goes like that. So I check there. I also check. You notice there's a lot of um, lymph nodes in the gastric area and the inguinal area and the urinary area. So this is the part, the tickly part that we all have to go through. But if my patient has a UTI, right, or any problems here in the genitourinary area or the pelvic area, all of these lymph nodes will light up. And of course, I check in the back of the knee and all the way down to the feet, especially with diabetics. Diabetics have a lot of hidden, what do you call that, pathologies. And of course, the lymph nodes can tell me where things are. So that's what we're looking at in palpation. Another thing we're looking at in palpation is, if I'm checking the body from head to toe, I'm looking for masses. I'm looking for things that, lumps or bumps that really shouldn't be there. So another way that I can look for lumps or bumps or different densities of like things in my body is via percussion. Now, what's percussion? Percussion is like drums. So let's show you medical. What does medical percussion look like? Well, let me explain to it what you're about to see in a moment. And the percussion technique is, it's like a poor man's ultrasound or a poor woman's ultrasound. You spread your fingers out, and then you like tap with your other hand, tap your fingers, and it's going to produce a sound, and it's also going to produce a feeling in your fingers. And the way they taught it to us on the first day is, they made us, tap on our thigh. And if you tap on the meaty part of your thigh, it's going to feel a certain way. But if you tap on like the bony part of your knee, it's going to feel another certain way. So when we do percussion, I do that to your abdomen, and I also do that to your chest, because I want to see if there's any densities in your stomach or in your chest. So let's watch this. So it'll at least give you an idea of of how to do it. Even though that's the doctor's responsibility, it takes years to develop that feel. But at least now you know what they're doing when they do that, if ever you see it. So let's look at this video.
Pinkles are so basic.
Okay. Love ads.
Hi, my name's Zach, this is Harrison. Today we're talking about percussion as part of the medical examination. So if you're a John Bonham fan, you're in the wrong place. Percussion is performed by placing the middle finger of your non-dominant hand over the area to be percussed and applying pressure with your middle phalange. You then use the fingers of your dominant hand to tap, like so, producing a note that gives you a clue as to the nature of the viscera underneath. Things that are hollow or full of gas, such as bowel or healthy lung, give a resonant percussion note. Things that are solid, like liver tissue or nasty consolidated lung, sound dull. For example, this Star Wars Mr. Potato Head is hollow and hence resonant to percussion. By contrast, this copy of Leo Tolstoy's War and Peace is rather dull. To avoid nasty injuries, remember that sound can be improved by applying greater pressure using your non-dominant hand. A more forceful approach with the dominant hand is rarely necessary.
All right, clever. A little bit of British humor for the morning, but you could see how your dominant hand kind of bounces on it, and you're not really like you're poking your patient. It's just like tap, 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 tap. And if you find something that's hollow that shouldn't be hollow, that's called tympanic. For example, you ever, have a lot of gas in your stomach and then I start tapping on that, it's going to sound like a drum. Or let's say if my patient's elderly and they have bowel obstruction, either cancer or IBD, intestinal bowel disease, or IBS, right, a really bad inflammation, it's going to sound dull. So you could play around with it so you can understand it, and we can even review that when we go to laboratory. It's the difference between like tapping on like your thigh, which is like meaty, right? But it's not as dense, and tapping on your knee, and that is percussion. And we do that. When do I do that? I do that percussion not only for abdomen when I want to try to find masses, so I know exactly where to put the ultrasound, and also I do that for lungs. So I want to see if there is too much mucus or too much fluid. We do it a lot when my patient has pneumonia because I want to see a fluid level. Pneumonia is when the fluids in your lungs get increased to the point where it starts drowning out your lung tissue, and that's never a good thing. And we utilize percussion to find the fluid level. Another time I use percussion is also, it's something called liver sign, especially if the patient has like cirrhosis or hardening of the liver. Their liver will protrude from the 10th rib on the right side, and if I'm palpating in that, percussing in that area, it's going to appear dull when it should appear a little bit less dull and more hollow. Mensuration is a fancy word for measurement, right? And they use it a lot for children. But again, back to the main reason why we're documenting everything, because we want to prove continuity of care. And again, just like that situation about my niece, knowing the previous data will versus the current data is very important, and constant measuring. And that mensuration, that is the responsibility of the medical assistant. So getting the vital signs, making sure that heights and weights are properly recorded. We'll review that real quick in lab, but that's your bread and butter, and take it seriously. It's not, don't take, that's also the other thing in nursing where come 1 o'clock in the morning, people stop doing vitals because, oh, they're alive, they're okay, but you never know when your patient's going to go south. You never know when the monitoring is going to lead you to trouble. So mensuration is heights, weights, any measurements, and mensuration with the pediatrics is, of course, head circumference, and for babies, it's CRL, or crown rump length. And we also do other mensurations or other measurements in obstetrics. Of course, we use fundic height, which is the measurement from mommy's pelvis to the fundus, or the top portion of their uterus. We measure that to see if baby's growing correctly, and the pregnancy is progressing. So you could see how mensuration is also a very important, or measurement is also a very important part of the clinical process. And last but not least, manipulations. Now, manipulations are one of the easiest ones to remember is range of motion. If the doctor is going to be doing things, and there's a thing called a goniometer. Let me show you that. Because range of motion, again, is also a measurement. So you're going to see something like this as like a protractor kind of thing, like this. Let's see if I can get a larger image of it. Yeah, it looks like this. Looks like a protractor, and then we put that on your joints, and then we measure the angle or the range of motion. And heck, I used to do them all the time. I used to be a medical assistant in a orthopedics, so we have to chart down either the improvement or the lack of improvement of my patient's movement. That's one form of manipulation. There are other manipulations. There's a whole bunch of manipulations in physical therapy, but manipulations is moving the patient around to elicit data. Sometimes we do manipulations to um, to ascertain a diagnosis like appendicitis. So let's minute. See if they show that. Let me just explain it. Um, if you like, for example, if you have, there's a test, and I forgot the name of the manipulation, but there's a test where if I raise your left leg straight, right, and you truly have appendicitis, it goes, if it's really appendicitis, because of the way the nerves are set out, it will elicit pain. Another manipulation for appendicitis is, it's called rebound tenderness. If I press down on the left side of your abdomen and then I release really fast, the pain will elicit in your McBurney's point, also known as the part where the appendix is, where the pain's going to be in your right upper quadrant. So we do a lot of these little strategies and little tricks, that knowing our anatomy, that can also lead us to the diagnosis. And so that's the parts. Let's see, as a review, those are all the 6 examination methods. So know your, let's see, know your examination methods and what they do. Research and look up your examination positions and what they look like, and what is the most common test that we do. Like, for example, sitting is always the interview, and we could do venipuncture. Supine or recumbent or dorsal recumbent, like EKG stuff. Lithotomy, obstetrics. All right. Prone, I could do proctology. Knee to chest, I could do proctology, right, which is especially for males greater than 30 or 40 years of age. I should do digital rectal examination, or DRE, for prostate. So those are the kind of things to think about. Now, we talked about head to toe, where we look essentially just head to toe, inside to outside, utilizing those 6 methods. And let's see if we went through all. And of course, the steps from top to bottom, from inspection all the way down to manipulations. All right, so that's one set of notes. Oh, I even put a nice picture here. I didn't know I did that. Here's this nice picture, so you know your positions, and kindly look up the more common things for each one. And do you see also, I like this picture too, because it also properly shows the draping on how do you properly drape your patient, in pink right there. Now, how to set up exam room, MED 140 review. I believe that's a video, a student made video that I found, and it's right there. Oh, another PowerPoint of exam positions, and I put them there as well. Alrighty, I think that's it for this week with the things that you need to know. And again, if we were in class, we would be actually doing them. But I'll reserve, we'll reserve some of these things for the laboratory. And the laboratory will be in 2 sessions. There'll be 2 days that you have to come to class this term. Actually physically come to class. And if you can't, you got to get that to me. So at least maybe I can have some sort of alternative assignment or something. But honestly, you paid for the lab. And heck, I even suggested to another student because she has high risk family members in her home and she doesn't want to be at any risk for COVID. I can even hold it outside in the parking lot. I will go to that length so that you will get the training that you need, and it's different when you're face to face. So in order to, if you're already in this, I believe there's only one person today, and you'll get, of course, full credit for being in lesson or being in the class today. And for those of you who didn't, I have an alternative assignment. Please look at the video. Please give me a call so you can get credit for the lesson. I'll give you another assignment on top of what else is due. So what's due for next week? Discussion 2 and quiz 2. At least start it so I can have attendance for you by the weekend. For those of you who aren't on this Zoom session, please. And that's all I got right now. So any questions?
No, no questions.
No, you're good? All right. So you got your marching orders, and look out on the announcements for the future laboratory dates. Okay?
All right.
All right, Ms. Gonzalez, have a good one. And
You too.
I'll talk to you next week.
Thank you.
Bye.
Bye.